Okay, we shall begin. Welcome again, everyone. As those who are in the audience will know, this is the second day of a conference on the governance of social listening in the context of a serious health threat. We have arranged for this session to be in the evening for the benefit of our colleagues who may not be able to take time off work. So we'd like to again welcome those of you who are present here today and those who are joining via Zoom. I'd start off by firstly thanking all of our presenters who are here. So you would have seen from the conference booklet that they have joined us from literally around the world. So we're very grateful that they have traveled long distances, fought jet lag in order to be with us, and we've had wonderful discussions so far from the very start of the conference yesterday. And of course, we will conclude in the afternoon tomorrow. The session tomorrow will continue to be available via Zoom, so those who are interested in the discussion, you're very welcome to participate via this particular platform. I'd also like to express a note of grateful thanks to our donor, the Wing Foundation, because this event would not have been possible without their very generous support. We are also grateful to many of our colleagues, especially from the Law and Technology Center, as well as from the Medical Ethics and Humanities Unit at the medical school, because they have been strongly supporting our event, participating in the discussion, and we greatly value their not only their contributions, but also their help in co-organizing this particular event. I should backtrack in the sense that for those who are not otherwise already familiar with the Center for Medical Ethics and Law, we are a joint center operated by the Faculty of Law here at the University of Hong Kong and also the LKS Faculty of Medicine. So I am the representative of the law school, and my colleague who will be speaking in a short while is the representative from the LKS Faculty of Medicine. So that said, Gilberto, is over to you.
Thank you so much, Calvin. Good evening again, everyone. I am aware the fact that there are some people in the audience who are from the healthcare professions. I just want to say a special thank you and welcome to all of you. The reason why you'll be able to attend this special evening session is because of Calvin's very considerate arrangement of having this. Otherwise, we would have finished by 6 o'clock. And because of this arrangement, many of you here in the audience had to eat finger food as opposed to another big meal in a Chinese restaurant, which you might actually be grateful for. But thank you so much for this arrangement. And for those who are not familiar with social listening, I think Calvin gave a very succinct description. We are here to look at how social listening and the governance of it could be further examined in the context of, for example, a pandemic or a health care crisis. We're not here, however, to deal with issues, complaints arising from social media posting, etc. I just want to make sure that some of the members in the audience, would not use this as a platform to seek legal advice. I don't think that's the purpose of this. Okay, thank you so much, Kevin. Back to you.
Thank you so much, Gilberto. So we are going to start off with the first segment of our presentation, and this will be made by two of our colleagues from the World Health Organization. We're very delighted to have them here. The first speaker is Dr. Sandra Machiri. So Sandra has done wonderful work in getting together with her colleagues in Geneva, a hugely important document, and that's the Infodemic Insights Manual. She will be introducing us to this manual and to explain how social listening fits in to this particular important work. She will also highlight to us what are some of the considerations that we want to take on. Again, for those who are joining us for the first time, one of the output of this conference is to support ongoing work by the WHO to develop an ethics guidance document on social listening. So if you don't already know what social listening is about, first of all, a document would have been sent to you as a registrant of the event. This provides you with background information about what social listening is about, as well as references to key documents that will be referred to over the course of this particular session. Well, with that, I should also note that, of course, Dr. Sandra Machiri's illustrious CV is already set up in the conference booklet. You should already have seen that. It's on page 20 if you'd like to know. And that's it. Well, it's over to Dr. Machiri. Welcome to Hong Kong, and we look forward to hearing you.
Good evening, everyone. I hope we all had a pleasant day, and I'm very happy to be sharing the journey of infodemic management in terms of what we've done as the World Health Organization over the past 3 years. Okay, so I work as a technical officer for infodemic management in the Health Emergencies Program. And we basically have been going through this journey in coming up with infodemic management definitions, tools, kits, guidance documents over the past 3 years. And this is work that I'm going to showcase that has been happening since 2020. So we all know that we're living in a very noisy environment, and we are seeking for information on online platforms, on offline platforms. We're sharing with friends, we're sharing with family, we're discussing. And I think this is something that we can all relate to, especially after going through the COVID-19 pandemic. And it can be very overwhelming. And we need to ensure that we find ways of managing this. And this is where the infodemic then came into play. And this definition is something that we've been referring to since yesterday. It's an overabundance of information that can be accurate or not. It's on the digital, physical platforms, and it's accompanying a public health event such as an outbreak or epidemic. And why focusing on the outbreaks or the epidemics? It's because the impact in terms of impact of life on life, impact on the health system is high when it comes to emergencies compared to anything else. So we have over 91% of our member states that are already reporting on infodemics. So here I just pulled out a few examples that are coming from all over the world. We have Nigeria, Germany, Sri Lanka. They're all now reporting on infodemic management. So it's not just something that we are speaking about in the offices, in the corridors, but it's something that's already being implemented by a lot of our member states. And over the past 3 years, like I was saying, since infodemic management was born, so to speak, we have gone through a lot of programmatic responses. We have come up with frameworks and strategies for action, where we're calling for the whole of society framework to respond to infodemics. And we're also looking at the impact of COVID-19 on infodemic and on the responders. And here we've also tried to document some of the stories from the health workers that were responding to COVID-19 in terms of how they managed to go through infodemics, how do they manage them, what are some of the system things that they think should have been done better for them to respond to infodemics in the future. And then we're also looking at the science, where this is something that has also brought us together here, where we're trying to define the ethics guidance on social listening and infodemic management. And this is just amongst a lot of the documents that we've come up with to inform the science of infodemic management. Then we also have country-specific tools and partnerships that are in place. These are tools that can be implemented at country level. Like I was saying, we have 91% of our member states already reporting on this, and they're also making use of some of these tools already. We have the manual that I'm going to be speaking about that speaks about steps of coming up with an infodemic insights report. We also have the EARS platform that was referred to yesterday, where we're looking at early artificial intelligence response in social listening. And then we also have various tools that we cannot name one by one, but there are a lot of tools that are in place that countries are already making use of. And what we've really tried to do is to make things practical. Let's take things from the theoretical space into a practical space where someone who's in the field can actually make use of them. And here we've also developed the profession of infodemic management, because we've had trainings of over 1,300 infodemic managers all over the world that have been trained on how they can respond to infodemics. And this all started in 2020, and we've gone through a series of conferences, training platforms that we've done, and we have that community that is growing. So what we have come to understand is that infodemics affect all parts of society. It doesn't matter where you're living, where you are, who you are within the society. Everyone is affected. And especially during outbreaks and emergencies and in immunization programs, this is where we've seen the hugest impact in terms of affecting people in terms of morbidity, mortality, and even the cost on the health system. So all this is what we have seen as the infodemic impact on the people's lives. So here, when we define infodemics, we don't just focus on the misinformation. We also want to look at the questions that people have. We also want to look at the concerns and the information voids that are there. And looking at the first three steps, this is where we have more impact in addressing. We can address the questions, we can address the concerns, we can address the information voids. There isn't much that we can probably do in terms of the misinformation, but let's make that wholesome approach so that we have that infodemic management response that is going to be effective. And then we also want to look at just the information environment and also consider the information overload. Also consider the risk factors, and this is where also trust comes into play. So infodemics don't just survive on their own. We need to really look at the information environment. What is circulating? What are people talking about? This is where we can get our insights from. And also not forgetting the risk factors, which can be vast. They can range from the trust issues, they can range from access to health services, they can range from social determinants. So all that also comes into play when we speak about infodemic management. And we are saying that we need to have a whole of society approach where we're looking at multiple interventions. This is why we're saying that we have trained over 1,300 people in infodemic management. And this is not anyone in specific. It's not like you need a certain qualification to be an infodemic manager. You'll find that a lot of the people have huge backgrounds. They have different backgrounds. Some are in law, some are in the public health, some are in medicine. It's vast. So we have everyone playing their role in terms of infodemic management and trying to address all these questions and concerns that are coming out. So we have a taxonomy that is in place where we are classifying the types of interventions that we're going to come up with. So sometimes we'll look at monitoring and detection of the narratives. Sometimes we define the science and health communication. We can look at the training aspect. We can look at the engagement. We can also look at the laws, regulations, and ethics, which is something that we are discussing within this meeting. And this is stuff that you can also go through at your own pace because we have shared this. And when we speak about social listening, we're saying social listening is something that comes into play within our integrated analysis to understand the concerns, questions, and information voids. So here now we're starting to speak about the infodemic insights. This is what we will then use to come up with recommendations and come up with solutions to the infodemic insights problems. So when we're defining social listening, I think over the past 2 days, we have had different definitions of social listening. And even if we go online, you search for social listening, you'll find different definitions. But in the public health context, and this is what the World Health Organization looks at, we're looking at understanding the community's concerns. We want to understand what it is they're going through, what it is they're discussing. And this is a bi-directional feedback mechanism because we're looking at the community and then we're also looking at the health authority. And when we then talk of social listening, this is an aspect that comes into play when we're looking at infodemic insights. So we combine different data sources, and social listening is one of the data sources that we'll make use of. And we are trying to analyze data that is online and offline. We want to analyze data that is that will provide the infodemic insights, and that will be proactive and not just reactive. So we want to avoid the situation that we had when we were then faced with COVID-19, but we didn't have strategies in place. So this is why we need to continue speaking about infodemic insights, because we want to be prepared even for the next pandemic. So here on the side, there are examples of some of the reports that are already coming out. We have the Africa Infodemic Response Alliance that gives us reports on a weekly basis. They analyze what is happening within the African region and they give recommendations, because sometimes countries are not able to do this for themselves, but the regional office can provide those insights and provide recommendations as to how they can do their programs. And then we also have an example from the US CDC and an example from UNICEF. So this is just to show how much the infodemic insights are now being utilized in the different organizations in different regions. So here we want to now speak about the Infodemic Insights Manual that we have also been seeing being showcased from yesterday. And here you can also scan and access it. This manual helps us to understand the information environment. So in as much as epidemiology will look at the disease, infodemics will look at the information environment. What is it that people are talking about? What are the narratives? And this helps us inform the emergency response of a health program. And then we also want to make sure that we inform the adaptation of outbreak or emergency response as the situation rapidly evolves. So these steps go through steps that you can implement rapidly, get your recommendations, and inform the program that you're going to. So this is a manual that was co-produced by the WHO and UNICEF, and it was published in the last month. So we can also make use of this manual, share it if we have anyone who's in infodemic response. Like we said, there's no one who's specifically targeted or specifically trained as an infodemic manager. We can always come up with a team, and this manual actually helps us to just implement the steps rapidly. So infodemic management does not live in isolation. It's also speaking to other strategies that are in place within the emergencies programming. So we have these two examples, which we are going to be going forth with within the next couple of years, where we're looking at the preparedness, the resilience in terms of looking at emergent threats. So here, infodemic management also plays a role in making sure that these strategies are implemented and come into play. And then we're also seeing that we're expanding infodemic management into influenza programs. So we also have strategies that are in place that are not just specific to WHO. Some of them are co-produced by partners, as you can see, like on the operational framework for demand promotion, that we are also working with partners. So a lot of people are now implementing infodemic response into their activities. So whilst we are looking at all these steps, working with the communities, trying to understand the narratives that are going on, we also need to look at the ethical side of things. And this is something that we've been discussing, and Andreas will also go into detail as to how we have been trying to implement that. And we're looking at the ethical principles that we can look at when it comes to the data collection processes. we're looking at the selection of that data source. Is it a good one? What are we going to do? And then in reporting and the analysis stage. So here's where we want to actually think about the ethics that come into play into all these stages, even as we go through the 6 steps of the manual. So for the key takeaways in terms of what I have been discussing over the past few minutes are that already infodemic management is being implemented at country level. What we need to do is make sure that the recommendations and the insights that we get going forth are going to advise and speak to making sure that our interventions are effective and they're useful. And we want to make sure that even the health worker whoever's responding to the infodemic at the country level, at the grassroots level, really has something that is tangible that they can make use of, but at the same time considering the ethical issues. So here I'm going to provide you with some of the resources that are in place. We have a news flash that we produce every 3 weeks. Currently it's every 3 weeks. Here we share some of the activities that are being done across all the countries and the regions. So you're also free to share if you're doing any work in infodemic management, please also share with us. And this is a space where people can have updated information on what's happening in the infodemic management world. And then we also have these courses that are on the Open WHO platform. This is a platform that has a lot of courses that you can take at your own pace, and you can understand what infodemic management is all about. And all this is work that has been done by the World Health Organization with partners and experts over the past 3 years. And all this, just to mention, has been done with advice and consultations with external partners. External experts have been putting their input into everything that we have come up with as the World Health Organization. So here we also have an email address and the website address, website link that you can make use of. Interact with us, talk to us. We are free to expand this field together. So thank you very much.
Thank you so much, Dr. Machiri. Hello, everyone. As you see on the program, we are now going to be joined by Dr. Andreas Reis, Dr. Machiri's colleague, but an expert in bioethics, public health ethics, more specifically in the context of our discussion today. As you'd see, Dr. Reis has got immense experience working in this space. He is the co-unit head of the Health Ethics and Governance Unit at WHO Geneva. And he has been directly involved in almost all, if not all, of the key ethical guidelines that we see now available in the public domain. So he's going to share with us some of these ethical frameworks that have been published by WHO and help us to think through some of the ethical challenges that Dr. Machiri has highlighted. So it's over to you. Thank you so much, Andreas.
So good evening, everyone. And first of all, thank you very much to Calvin Ho and his colleagues at Hong Kong University for the generous invitation, not only to WHO, but I think to all of us. And it's really been a fantastic meeting so far. So thank you very much. After a brief background, I will say something about the process of WHO guidance development. And then most importantly, I will discuss some of the relevant WHO guidance that's already been published, notably on public health surveillance, on digital proximity tracking, and the ethics of AI for health. So I don't think I need to repeat to this audience that infodemic management raises a lot of ethical issues. I think what has come out very clearly from talks like David's this morning is that I think infodemic management has become actually a crucial public health activity in the recent years and mainly triggered through COVID. So I think it's really sort of a new tool that we have in our public health toolbox, and that hasn't really been closely examined regarding its ethical ramifications. And so there are a few efforts by NGOs, by other organizations to discuss the ethical issues so far. But I would argue that a comprehensive ethical framework so far is missing. And also, as you heard from our colleague Sandra, member states of WHO are already doing quite a lot of activities in this area, but they need guidance on how to address the ethical issues that come up. And this is why we were contacted by our colleagues about a little bit over a year ago to collaborate as a WHO health ethics and governance unit with our technical colleagues to develop guidance on the ethical issues in this area. And this is actually very typical for our health ethics and governance unit, that we almost always work together with a WHO technical department, whether it's ethics of COVID or ethics of HIV or ethics of vector-borne diseases or organ transplantation. We always have a very strong link with the technical units in our work. So what is the process for the guidance development? I think you've already seen that slide. So after quite some discussions, we finally got off the ground an expert group on the ethics of social listening and infodemic management in February this year. And again, this is a very close collaboration with our colleagues in the Health Emergencies Program. We did what is required in the WHO guidelines development process. We established an international expert group, and you're actually not required to read all this. You can find it on the website. But just to say, it's a very multidisciplinary and very global experts from all the corners of the world, from the 6 WHO regions, and notably from the ethics and human rights and law side, but also from the technical and implementation side. And we are extremely fortunate that we have 2 excellent co-chairs who you got to know here, Isabella Balalai from Brazil, and of course, Calvin, who has brought us here together. And they are guiding this process in the very frequent meetings with the Secretariat. And of course, I'm also very happy to see several of our experts in the room as well. Here you can see the terms of reference of the expert group, and I just want to highlight 3 things. So first of all, the remit is to develop an ethical framework, maybe more from the theoretical side, but our colleagues were very insistent, and I think some other colleagues today also and yesterday highlighted the need for developing practical tools and for implementation. So we shouldn't just stop at the theory, but really try and make this implementable. And finally, since this is a very quickly moving field, we are also tasking the expert group to help with discussing issues that might need further exploration and emerging issues. Now, what's also very important in WHO's technical documents is to review the evidence. Now, I think in the field of ethics, this is not necessarily something that can be taken for granted. Actually, there are also some ethicists who are quite violently opposed to, let's say, having Cochrane-type reviews and meta-analysis of ethical issues. But at WHO, I think we have, with our guidelines review committee, found a very good solution, which is sort of in between. We do have an obligation to do due diligence and do a review, a very thorough review of the literature, which is, in this case, a scoping review. And we are very fortunate to have very good partners or experts in doing this in our center at the University of Zurich. This is led by Nicola Bellandorno, together with Federico Germani and Giovanni Spitale, who are here with us. And they have done really a fantastic job wading through thousands of articles, and they already presented yesterday. So I will not go into details here, but just to say this piece of literature analysis is being combined with the expert opinion and the expert group discussions to formulate the guidance in the end. Now, as I said, we are not starting in this space from scratch, although many new issues have come up and keep coming up. There are at least a few WHO ethics guidance documents that we can draw on. And the first one was mentioned this morning. It's the first ever WHO guidance on ethics in public health surveillance, published already 6 years ago. How time is flying. And this was produced for quite a large target audience, mainly public health agencies, but also disease programs and NGOs who are active in surveillance. And I won't go through the whole document because it's, I think, about 40, 50 pages, but just a few highlights that I think are particularly relevant to the discussion of today. So first of all, ethics is often perceived as the naysayers or the people who put up hurdles. And I think it was very important for the expert group at the time to say, this is not, sort of a negative, document. We are starting with an affirmative duty, actually. So the right to be counted, what doesn't get counted doesn't count. So there is an obligation for countries, but also, for example, for companies to have surveillance programs to detect problems in their populations, in their employees. And actually, there have been, for example, employees of companies fighting for these kind of programs. So there is a affirmative, a positive duty by countries to develop comprehensive, feasible, and sustainable public health surveillance systems. And then for countries that can't afford to do that, there's actually an obligation by the global community to help them. Now, of course, there's a question, would we from now on consider social listening so essential that this would fall under a similar affirmative duty? That is, I think, still to be discussed by our expert group. Secondly, a key guideline was that a transparent process by a government should be followed to plan and carry out these surveillance activities. And again, to be discussed in this new paradigm of social listening. Of course, data quality and data security is for sure a key issue that has only been magnified by, I think, the advancing technologies and AI and so forth. Another very big discussion that we had around the surveillance document was the need for informed consent. You know that in research ethics, in research projects, informed consent is one of the very central concepts. And after a long debate, the expert group reached a consensus to say in surveillance, that is actually not the default for different reasons. It's normally not required except in very specific circumstances, where, for example, in surveys, where it is the norm. And that's also something that I think needs to be further discussed in this area, how to deal with this complicated issue of informed consent. And then a few other aspects that have been highlighted already, the protection and engagement of vulnerable populations, especially a duty to minimize harm and maximize benefit, communication of results to target audiences. Again, an interesting concept coming from research ethics, essentially. Now, how would we deal with this in social listening is also interesting question. Data sharing is, of course, a very sensitive area. In this case, WHO guidance says that this was justified for legitimate public health research purposes. But then also the last bullet point was very hotly debated. And the consensus was that identifiable data should not be shared with those that are likely to use them to take action against individuals or for uses unrelated to public health. And that, I think, is a real danger. And if this happens, then trust of the population could be really violated with very bad effects for public health potentially. And then finally, for this surveillance guidelines, I want to come to the governance question, which David Scales this morning already highlighted. We all know that all research with human subjects has to undergo ethics review. In most countries, we have laws and regulations. I think there is one or two where this doesn't happen yet. But by and large, that's an ethical obligation that is not only recognized, but also implemented. Now, often for public health activities, such as public health surveillance, there is no ethical oversight at all. Although some of these activities are quite similar to research. Actually, there's often a blurry line. And as you all know, surveillance projects can involve serious risks and ethical issues that may require oversight and advice. Now, there are only very few mechanisms that have been used in this sense. So I know that the US CDC, at least for some time, had some public health ethics advice group, consultation group. Public Health Ontario has such a mechanism. At WHO, we had for some time a public health ethics consultation service where staff in need of advice could get, or programs could get advice. And we also in many countries have national bioethics committees who have sometimes played that role, but could play a much bigger role. And I think what is very important is that we already anticipate the ethical issues that could come up in the design, in the planning of social listening and infodemic management, and that somehow we build into the future WHO guidance a suggested mechanism or maybe a menu of options how these programs could actually get ethical advice and could somehow be vetted against our guidance. With that, I would move on to the second document that I would just briefly mention. So as you all know, during COVID, there was a proliferation of apps, of contact tracing apps, with the goal of digital proximity tracking. And we published a guidance document in May 2020. This was developed by the WHO Ethics and COVID-19 Expert Group, again in collaboration with some other colleagues from the World Health Organization Emergency Program. And there were a set of guiding principles, namely proportionality, data minimization, voluntariness, transparency, and privacy-preserving data storage. I can't go into much more details, but it's certainly a document worth reading in the context of social listening and infodemic management. And the final document I want to briefly mention is our guidance of WHO from June 2021 on ethics and governance of AI for health. Again, there are a number of consensus principles. And as Joe mentioned this morning, there's no lack of principles, but the question is, of course, always, who will actually use these documents and who will see to the implementation of these principles. I think when we did this work, the scoping review actually revealed over 80 sets of international principles already in 2021. Just to mention one brief chapter out of that guidance, it's again on public health surveillance. And I think the experts are very concerned there about the use of digital traces that are not generated specifically for public health purposes and purpose limitation, but I think that would lead a bit too far. Now, just to come back to our current project at hand, so ethics guidance on social listening and infodemic management. Giovanni already showed the slide of the future structure as it is developing now. I think what came really very clearly through to me, and I won't go again over this structure, is really the practical guidance. And that's, I think, what I'm taking home also from this great meeting, is that we really have to make sure that we will develop targeted tools for different stakeholders, that we will include case studies either within the guidance or as an annex or maybe separately, that tools like checklists could be used by countries, and that we should probably follow the suggestion by Terry to use this step-by-step approach, how to build an infodemic insights report and really insert the ethics as we're going, and hopefully the countries will then not be able to sort of skip the ethics, because then they don't have to take a separate document, but they will see it right there. So that has been quite successful in some other projects. And Sandra mentioned there's already 7 or 8 training courses. Maybe we could dream of an ethics training course, ethics and infodemic management course, that could also go a long way for dissemination. So this is my last slide. I think it's very important to build ethics from the start, ethics by design, some people call that in AI, into the social listening and infodemic management programs. We are on it. As WHO, we're hoping to have a few more expert meetings in 2023. This is often or almost obligatorily followed by an extensive external review process. So if any of you experts present in this room would be interested to serve as external reviewers of a draft that will come out of this exercise, please write to us. We're hoping that we can publish this guidance in 2024, in early 2024, followed by dissemination and implementation activities. And I'll end with one of my favorite quotes by Stephen Hawking. Our future is a race between the growing power of technology and the wisdom with which we use it. Thank you very much.
Hey, yeah, I'm sorry. In the interest of time, Larry would have to move on. Sorry about that. Yeah. So, if ladies and gentlemen, if you again join me to thank Dr. Machiri and Dr. Reis for this really informative session. Thank you so much, and of course, wealth of resources. Thank you so much.
Next, we're coming closer to home, to Hong Kong. Now we're having a speaker from Singapore, who is Professor Kevin Tan from the National University of Singapore. He is an expert in constitutional and administrative law, and today he's going to tell us how Singapore stemmed fake news during the pandemic under the legislation of Protection from Online Falsehood and Manipulation Act. Thank you, Professor Kang.
Good evening, everybody. Thank you very much for hanging around for this late session. And first of all, thank you very much to Kelvin and your team at CMEL for inviting me for this conference. Today, I've been asked to talk a little bit about Singapore's attempt to stem or to control fake news with a particular piece of legislation which is quite interesting, which is the Protection Against Online Falsehoods and Manipulation Act, which we enacted several years ago. Now, when we talk about strategies in curbing fake news, and of course, in this conference where we are talking about social listening, it becomes very important what we listen to. And as we've just heard about the prevalence of infodemic out there, there's a lot of fake news. So in order for actions to work when we actually do some social listening, we must make sure that the information we get is actually accurate. So around the world, if you look at various countries and attempts to deal with this big problem of fake news, they have adopted several strategies, right? Legislation and regulation is one of the more common ones. You would find that quite a number of countries are actually looking at it or have already implemented some kind of legislation or regulation. Some other countries prefer not to use the instrumentality of law, but instead to work on media literacy programs and campaigns for the general population to get them to be more discerning, right? So rather than try to control what is eminently uncontrollable, actually, what you try to do is to get people to filter, to learn to be very effective filters of this. Another way, of course, is to jam, right? Using proxy servers and so on, just censor anything that kind of looks dangerous, block it, right? That's another model. And you could also, and I think 1 or 2 countries are experimenting with this, although I think it's more of a money-making scheme than a real regulatory regime, which is to start licensing people who use the internet. So if you want to run a blog, you pay a license, right? And if you want to get access to the internet, you pay a license. It seems to me to be more of a money-making scheme. Anyway, what we, not me, but what the Singapore government opted to do is to go for a combination of the first 2 strategies, which is to have some form of legislation and, of course, media literacy programs and campaigns. And if you look at this slide here, you'll see one of these I don't know what you call them, pop-ups that come up on your phone every now and then from our Media Literacy Council, right? And they come up with these a lot. I mean, every day there'll be new ones trying to educate the people who use the internet how to identify fake news. And there are different variations. So this one, for example, this is very current because right now, if you look at the man in spectacles there, that's one of the 3 presidential hopefuls for our presidential elections next week, right? So, and here, you know, this fake news is that he launches some high-tech digital project, which actually is absolute nonsense, right? And they tell you how to maybe spot a fake like this. There are others on phishing scams and so on and so forth. So a kind of mixture. But I will leave these media literacy programs alone and go straight to something I know a little bit about, which is the law. So in 2019, Singapore government, after almost 2 years of consultation, development, getting feedback, going through select committee and so on, passed the Protection from Online Falsehoods and Manipulation Act, okay? Otherwise known as POFMA. I will just simply call it POFMA now. And now it's become almost like a verb. Oh, am I going to get POFMA, you know? And so on. And is this POFMA-able? I'm getting these all the time now. So anyway, what is the object of this POFMA legislation? There are 4 avowed objects that it serves. Number 1, to prevent the communication of false statements of fact within Singapore, to suppress the financing, promotion, and other support of online locations that repeatedly communicate false statements of fact in Singapore, enable measures to be taken to detect, control, safeguard against coordinated, inauthentic behavior and other misuses of online accounts and bots. And finally, to enable measures to enhance disclosure of information about paid content directed towards a political end. You will notice that the latter 2 objectives hit directly at this use of false news, fake news, and other forms of manipulation to affect or influence the outcome of elections, right? And I wouldn't talk that much about this because we're talking about health epidemics, pandemics, and so on, and how we can try to control the type of news, the genuineness of the news that's actually out there. So these are the two major objects. And like I said, it took almost 2 years to come to final implementation, and it was commenced on the 2nd of October in 2019. So it's already coming up to almost 4 years, actually, which is really very fast. I just remember us debating this tremendously. Now, what is the ambit of this POFMA? It's not a very long bill, but it's a little bit complicated because it's got so many parts to it, right? Now, the first thing that we need to know about POFMA is that it only covers statements of facts. So obviously, if it's an expression of opinion, of satire, or parody, and so on, that's not covered in the Act at all, right? In fact, there was a very funny gaffe by the Media Literacy Council when they actually put out a poster that included parody, and then and everyone said, "Oh, I thought you said parody is not included," and actually it wasn't, and so they ended up apologizing to the public that, "Oh, we got it wrong, we were over enthusiastic." Well, anyway, that's been corrected. So only factual statements, right? Seems easy, not so difficult, not so easy after all. Now, what it actually covers is where the communicator must actually know or have reason to believe that the statement, first of all, is a false statement of fact, right? Secondly, the communication is likely to affect one of these 6 objects, right? Number one, if it's prejudicial to the security of Singapore or any part thereof. Number 2, prejudicial to public health, what we are talking about, public safety, public tranquility, or public finances. 3, prejudicial to friendly relations of Singapore with other countries. 4, influence the outcome of an election. 5, incite feelings of enmity, hatred, or ill will between different groups of people. And finally, and I put this in red because I'm going to come back to this in a while, diminish public confidence in the performance of any duty or function of, or in the exercise of any power by the government or any organ of state or statutory board. Now, the reason I want to lay this out is because out of these 6 sort of concerns, 4 of them have already been talked about, it's already in the Constitution and so on for the longest time. So there's really not much debate about it. But what is debatable, which is new, which is the objective of preventing, influence on the outcome of an election, that's new. D is new, and F is completely new. And I put it in red because many of us at the Select Committee were actually concerned that this was a violation of the Constitution, right? But we come back to that. Now, what happens when there's a piece? Okay, so let's not talk about what constitutes a fake news first. Let's talk about what happens if indeed, right, a fake statement of fact goes out there. You've got a number of possibilities under the Act where any minister is permitted to issue one of these following directions, right? Type of directions. So you've got a correction direction, a stop communication direction, an access blocking order, targeted correction order, disabling direction, general correction direction, and a declaration of online location. Let me go through with you very, very quickly what they are. The main differences between these various directions are against whom the direction is directed. So obviously, for like a correction direction, it will be individual owners of a website, whereas something like the disabling direction would be targeted against an internet intermediary, a platform, and so on. So it's slightly different for each one. Now, I've given some numbers in there. These numbers are up to date as of 30th June 2023, issued by the POFMA office in Singapore. And these are the numbers. So since 2019 till now, there have been 85 correction directions that have been issued, 3 access blocking orders, 15 targeted correction orders, 5 general correction directions, and 4 declaration of online locations. A correction direction simply means that a person who is asked to put up a correction direction has to put a notice on the close to the article which it is affected and state that this article contains false facts. And in summary, what these false facts are. You do not take it down. It exists side by side. I've got a screenshot. I'll show you one afterwards. It exists side by side. And so the idea, and this is kind of the innovative part of this particular legislation, because everyone is concerned that you could make use of this to clamp down on freedom of speech. You make use of this to jam all your political opponents and so on. So the government said, no, we're not going to take down anything. For most of the cases, you leave it up there and we'll tell you what the real story is. And so readers can choose to make up their minds. So I've got version A and our version, and then you read and you figure out what's the correct news, which one is news, right? 85 correction directions, which is actually quite a lot, but about more than half of them were issued during the pandemic period, where you had a lot of people saying things like, "Oh, if you take ivermectin, you will, it'll cure you of COVID," and all kinds of actually quite amazing stuff that was out there. I don't know, you drink some tonic and it will cure you or prevent you from getting COVID. No need to get a vaccination and so on and so forth. So quite a few of them were actually COVID related, about half of the correction directions. Those are not so controversial, not as controversial. The controversial ones tend to be more politically inspired, the kind of information that would go out there in relation to what the government is doing it right, doing it wrong, and that sort of thing. Okay. Now, with the correction directions, you will actually see two versions of the news, so to speak. But the ones in red, the stop communication direction, actually basically asks for the material to be taken down, sometimes known as a takedown order. And in the case of a disabling direction, which is directed at an intermediary, you no longer make that material available. So these are the much more draconian ones. So first problem is that we have no idea how the government makes a distinction between when to issue a correction order and when to put in a stop communication order. All that was said during the second reading of the bill was that it would be only for very serious cases. So at what point something becomes not serious to serious, well, it's anybody's guess. Up to date, they have not issued any of those stop communication orders or the disabling direction. Now, if you fail to put up the correction direction as instructed, right, then you face the possibility of penalties. And as you can see on the right-hand column, these are fairly draconian, right? 20,000 minimum fine, up to $20,000 fine for an individual or 12 months imprisonment. And if it were a corporation, for example, it's $500,000 fine, right? And it kind of goes down. An intermediary might be fined up to $1 million. Of course, you can't send the intermediary to jail. So yeah, you have a very high fine, right? So it's very serious, it's taken very seriously, and it is enforced. Now, what happens when you are POFMAT? What happens if you're asked to put in a correction direction? What can you do? Well, you've got two tiers of appeal. The first one is to go back to the minister who ordered the appeal itself, ordered the order itself, and you ask the minister to reconsider. Here it's actually quite interesting because one of the complaints that we had when the bill was going through Parliament was that, well, the minister can just sit on it, right, forever, and then nothing happens. So actually they passed subsidiary legislation now to require the minister to act on an appeal within 2 working days. And of course, there's a default position. If you don't act within 2 working days, then it's considered as if the appeal had failed. Okay, if you fail with the minister, you can go to the High Court. And here, under Section 17 of the Act, you may apply to the High Court for either a variation or setting aside of the minister's direction, right? And the court actually has only 3 grounds for setting aside the direction. First, if the person did not communicate the subject statement in Singapore. Secondly, the subject statement was not a statement of fact or was a true statement of fact. And finally, if the direction was impossible to comply with, right? Sometimes technically some things can't be done. Okay, so what does a correction direction looks like? If you look at this, right, if you go online into Google, you get fake news because you see something like what you see on the left. This is a graphic produced by no less a venerable newspaper than the South China Morning Post. And this is what they think it looks like. It doesn't look anything like this with this huge false sign chopped on it. Nothing like that. It looks exactly like what you see. This is Kenneth Jeratnam's correction notice, which I plucked off the internet yesterday. Kenneth Jeratnam is a leader of the Opposition Reform Party. And here it actually tells you what the correction notice is, right? A Facebook post below dated this day contains false statements of fact. And then it tells you in summary what the correction is. And then it gives you a link to a government website, right, known as Factually. It's actually part of the POFMA office. And it will tell you in detail why this particular post was wrong in fact. So, not a bad thing, right? And in fact, when they started issuing this, all of us thought, wow, this is one real good way to go get information from the government, right? Things that we don't know. So one of the first, and so there was a group of people that started posting. One of the best kept secrets in Singapore is still secret. All right. What is the salary of Ho Ching? Ho Ching is the wife of the Prime Minister, and she was for many years the CEO of Singapore Sovereign Wealth Fund. So they started posting, oh, Ho Ching makes $99 million a year. And it just kind of went crazy like that. Government simply POFMA'd them without telling what the salary was. So obviously, you know, that kind of baiting didn't quite work. But in any case, that's how this thing is supposed to work. So what's the main advantage, the pros and cons of this particular piece of legislation? The main advantage is that, in a way, your freedom of expression and of speech is minimally curtailed, in the sense that it's still up there. Whatever you say is still up there. Doesn't affect opinions. So I keep telling people who want to put things online, please, can you make it sound like an opinion? Like, you know, I have thought about this and maybe this is what is really happening, rather than A, B, C happen, right? No, there are many ways of doing this, right? Or you can make fun of it, and you wouldn't get POFMA. But those who do, you know, they are actually intentionally wanting to be called out. In a way, being POFMA is a little bit like almost a clickbait now, huh? Because if you're POFMA, everybody wants to read. Everybody suddenly is flooding to Kenneth Jeratnam's Facebook just to see, and then everybody wants to friend him and so on. So, you know, sometimes you're using it for a slightly different effect. So only facts are targeted and the original expression remains. That's the main advantage. The main problems, the teething problems that have emerged quite clearly are, first of all, what are facts? Who decides what a fact is? Right now, the minister decides that something is a fact, right? So who gets to tell the so-called truth? And when do opinions become facts? Right? I'll tell you with respect to the first major case that came up, why this is a problem. And it has to do with this thing about reposting or sharing. In fact, what happens if you simply say, a Malaysian newspaper reported the following, or so and so, right, reported that there was a rumor about, you know, a disease, for example. Now, that's actually reporting. I mean, if you purport to be a news website, well, that's what you do, right? You tell people, your readers, what other people are saying, and you package it. Here, you can still get into problems, as we have seen in the online citizen case. The third problem is that there are constitutional difficulties with the validity of executive action. So the act itself was the constitutionality of the act itself was actually challenged. Went all the way to the Court of Appeal. There was no problem with the constitutionality of the act, but executive action that's taken by individual ministers could still violate the constitution. And that part of it has not been really thoroughly litigated. And the fourth thing, although the minister is told that he has to respond to any appeal within 2 working days, the courts cannot be controlled in the same way. So in the very first case, or the case that went up involving the Singapore Democratic Party, it was cleared within 2 days by the minister, appeal denied, but it took over 2 years in the courts for a finality on the decision of whether or not a fact, a statement of fact had actually been made that was fake. So I know we're kind of running out of time, so I'll try not to get too much into the technicalities of this, but it is technical, unfortunately. So on the left, you see our freedom of expression and speech provisions, and the key operative words are in red, right? So this is a derogable right. Every citizen of Singapore has right to freedom of speech and expression, but it's taken away in 14.2a when Parliament, right, by law imposes restrictions which it considers necessary and expedient in 8 areas. So forget about the left side, look at the right side in the box now. Number 1, interest of security of Singapore, any part thereof, friendly relations with other countries, public order, public morality, parliamentary privilege, provide against contempt of court, provide against defamation, and provide against incitement to any offense. Now, if you read this, you will recall what I said earlier, that many of the objects of POFMA actually tally with the restrictions that are permissible under Article 14.2a already. So here we go. If you just look sort of side by side, what you don't see on the left is what you see in red on the right? Diminish public confidence in the performance of any duty. So, if I make you lose faith in your government, you can POFMA me. Well, it's not according to the Constitution. That's not a permissible derogation, right? In any case, the question of constitutionality was actually raised in 2 cases that consolidated in 1 appeal. I'll just, the first case involved the Singapore Democratic Party, the second one, the Online Citizen, which was an online platform, and it culminated in a Court of Appeal decision in the Online Citizen case. The question was whether POFMA violated Article 14 of the Constitution. The court held no, it did not, because they took POFMA as a totality rather than individual objects. That means they said that if your confidence in the government is shaken, and it could well lead to public order problems, right? So they took a very wide reading of this idea of public order. So, okay, that's fine. What kinds of speech then are protected under Article 14? And this is one of the disturbing things in the TOC judgment, where the court said that false speech is not worthy of protection, which is not what the Constitution says. Because if you look at what the Constitution says, it doesn't talk about false speech or truthful speech. You end up classifying speech. All it's concerned with is the effect of the speech. It could be totally true and I can still restrict you. That's what Official Secrets Acts are all about. I mean, it's worthless if it's not true, right? I mean, then why do I stop you from speaking? But it's true, and I'm saying you cannot speak. So therefore, the whole of Article 14 is really about effects of speech rather than types of speech. So I can put out fake news out there, or fake speech, right? I can tell people, hey, I descend from Napoleon, which is not true, of course. But so what? What is the effect of that? Nobody cares. So all speech actually is protected. And this is where I, with respect, disagree with the Court of Appeal. Now, then the question is what happens with proving the truth or otherwise of the speech. So the 2 cases I mentioned here, the first one, Singapore Democratic Party against the Attorney General. The purported fake news that went out there was that there was a population policy paper which suggested the guy in red on the right, that's Chee Soon Juan, Secretary General of the party. Oh, 1 minute, okay. The point that he put out there suggested that the employment of PMETs in Singapore, the professionals, managers, executives, technicians, was plunging. This was not true. Ministry of Manpower came back with all the statistics to show why he was wrong. So by the time it went all the way to the Court of Appeal upheld 2 of the correction orders, and they actually withdrew partially one of them, which was a little bit suspect. But The main case was the online citizen case. And this is where I said it was a real problem, because what was done in the case of the online citizen was that it simply reported that a Malaysian NGO called Lawyers for Liberty had issued a press statement, and it told you what the press statement was, that there was this inhumane treatment of prisoners in Singapore, in Changi prison, and particularly of death row prisoners. And I mean, it gave these very graphic descriptions of what happens if you hang somebody and the person doesn't die. And then what they do, the prison officers are trained to kick your neck until it breaks and stuff like that. I mean, it's nonsense. But in any case, that was what was posted out. And so when they were issued a correction order, Terry Su, who ran the TOC until recently, said, no, I'm not going to carry the correction order because I'm a news site. I did not create this news. All I said is Malaysian NGO gave me a press report, and this is what the press report is. The Court of Appeal, unfortunately, and here again, I disagree with the Court of Appeal, seems to suggest that in the judgment, they said, well, we are not interested in who generated the news. If you put it there and it is a piece of news and it is a statement of fact, then the minister is totally entitled to give you a correction order. Now, one of the big problems, and I will end here, is if you have 3 correction orders, right, it's 3 strikes and you're out, you could end up being a designated site, in which case you will have further problems with funding and so on and so forth. Well, if I'm a news site and all I do is repeat other people's press statements, shouldn't that be perfectly fine? So what you're then telling news providers is that they have to do their own research, go and check on other people's news. And if it's wrong, I can't talk about it at all. That seems to me to be defeating the whole purpose of reporting. Thank you very much.
Thank you so much. That's very interesting. Don't know whether Hong Kong will have one soon. Dr. Hurley, she is going to talk to us about the Public Health England and the UK Health Security Agency and how the agency is dealing with social distancing.
Indeed.
Yeah, thank you.
Well, good evening and congratulations for making it through day 2. And thank you for patiently waiting. It's a delight to be here and a privilege. And Shir, and thank you. I want to say thank you to Calvin, also to the University of Hong Kong, and also a huge thanks to the vaccination workforce back in the UK. To listen or not to listen, social listening for public health threats. So the first slide I've got for you is the historical vaccine development and introduction of the routine vaccine programs in the UK. And if you could only read this really clearly, you'd see right at the top there was the development of Jenner's original vaccine back then. And that's where we first saw the anti-vaxxer. And there's some wonderful cartoons. If I had more time, I'd show you them, but you can look them up online, look up Edward Jenner and cowpox. And you can see some anti-vaxxers suggesting that if you take this vaccine, you'll have cows popping out from all over your body. Luckily, that didn't happen. And if you follow this timeline round, you can see the development and introduction of the routine vaccinations in the UK. And I'm particularly interested in this period here because selfishly, that's when I joined Public Health England. Back then, I had a very reduced knowledge of diseases. I'm a trained public artist. My background is in design and communication theory. And I just thought there was one type of measles and one type of flu. And I didn't realize just what a complicated business I was getting into. So during the time at Public Health England, as we rolled out all these vaccination programs, I quickly learned that we needed a raft of publications to support the healthcare practitioners to implement the programs and to communicate the risks and benefits of the vaccine and the offer of a vaccine. And that's critically important. We don't have mandation of vaccine in the UK. So it's very much an offer to those eligible to take up the vaccine and to take up the benefit from the protection of infectious disease. But we've always been listening, and they were listening before I joined them as the HPA. But Public Health England have been listening in a variety of ways, long before Facebook and Twitter, now X, arrived on the scene. And they have a National Immunisation Network weekly touchpoint, And that's a coalface touch point. It's a very quick meeting. Sometimes it can be 16 minutes, 16 lovely minutes long, but we've got 40,000 people out there and approximately 500 people on the network. And they can tell us very quickly what people are thinking and saying. And if there are any signals, any concerns, often that's the first place we hear them. We've also got massive inboxes. On a good day, you'll get 300 or 400 emails. And during the peak of the pandemic, we're up to about 1,000 a day. Online at conferences, we go around the country and we have about 36 events where we spend time talking to health professionals and the public. And often face-to-face is where people will tell you things that they would never tell you in an email. And they certainly wouldn't tell you formally through their mechanisms, through their managers, through the pharmaceutical companies, but they will share their personal thoughts there and then. And that's where I often get my gold. So let's whiz along right through to January 2020. So the first thing I knew was that there was an incident cell stood up because of an unknown virus. And the incident manager came rattling into my office and said, "Get me a map of Wuhan." And I said, "Sorry, where's Wuhan?" But I quickly discovered where Wuhan was and I got that map. And then I spent the next quite a few months turning my professional expertise in making publications to protect our first responders. And as a first responder myself, I felt this quite keenly because as London got locked down, we weren't locked down, we had business as usual. We spent a lot of time trying to urge vaccinators where possible to continue to vaccinate, continue to implement the routine program. They thought that because there was a pandemic, there was no need to vaccinate. We were like, no. There's more reason than ever, because what we don't want is a twindemic. So you can see a few examples of the resources we produce, and it's really critical to me to convey the importance of good quality design and provision of materials, because it doesn't matter how much good social listening you do, if you don't use quality materials and design to pre-bunk your public health measures, then you are less well equipped to debunk when you need to, and you get those safety signals. So then in February, Tedros declared an infodemic. Back in 2014, I was first invited to join the Vaccine Safety Network, and I met Dr. Tina Pernat and Liz Wilhelm. And they were the first people that were thinking clearly about the information channels that I was thinking about. I'd been concerned for a long time about the ecology of information, how people seek health information and how they find it, and the evolution and introduction of social media platforms, but nobody else seemed to be interested at that time. It was clear to me from the rudimentary social listening that I was doing in my department throughout this early period in the pandemic that the novel pathogen had caused this chronic information void, which people, as people do, were filling with all sorts of stories, some benign, some less so, some quite toxic, and some downright dangerous. But the novel space where we don't have the answers is the most difficult one for health professionals to honestly fill. One of the things I'm most proud about the department is how transparent we are with the difficult stories, because as health professionals, we often have to convey quite complex health messages. What governments and politicians want is beautiful, clean, 3-line messages. Get Brexit done. It's lovely, so simple, seems such a good idea. But perhaps history has shown us that this is not quite as good as it seems. So telling complex messages and telling complex science is a real skill. There's green books, there's all sorts of high-level scientific information, but it's my job to just bring it down to the simplicity, the most simplest forms, so that people can access that information and that they can understand it in a way that is meaningful to them. And to do that, I need to use the channels that they use. I need to use the language that they use. Often, and most often, I'm producing resources that are in a reading age of 7 to 11 years of age. And that's because in the UK, we've got a huge problem with literacy. An awful lot of the general public have got a reading age of less than 7 years old. So it's really important that I produce that material and commission it and use all the design skills that we have to create information that's manageable, easy to consume. And it's important that they get a fair and equitable chance to consider the risk-benefit profile of that intervention so they can then decide to take up the offer. Fast forward to November, and serendipitously, the VSN and WHO clubbed together, and I've got a lot of VSN friends in the room here tonight. You know who you are. And we undertook the certificate of training to become an infodemic manager. And I am an infodemic manager. I'm a qualified infodemic manager, but I consider myself an epidemiologist because I'm concerned with the infodemos, the actual ecology and how people find information. And just like a meteorologist, meteorologists don't just measure the weather when there's a typhoon or a storm. They're looking at it every day. And all disease surveillance and syndromic surveillance, it's happening all day, every day. And that's critically important so that when we see that horrible uptick, we can then think, how do we address it? So back then in November, the parties that knew that there was a vaccine coming down the pipe. I'd understood that this would take a number of years to develop and that we could be in this pandemic situation for a substantial amount of time. So I could have eaten several hats when my boss told me, no, vaccine's coming. We couldn't call it a vaccine then. We had to call it platinum gold or the monolith or some other secret name. But these were the behavioral change insights that we had, that a lot of people, about as few as 57% of people in the UK would actually take this vaccine. So when it came to rolling it out, it was critically important to convey the information that we had. And Mary Ramsey is the editor of the Green Book, and she was writing that Green Book in relation to the information on the vaccines, the efficacy, the safety, the eligibility, and the decision to roll this out to the most vulnerable, which meant there was predominantly, phase one was predominantly to older people, to older adults in care homes, and to also frontline health workers. So it's critically important to create positive sentiment in both of those groups. Some of you, or hopefully most of you, will recognize this sticker. The humble sticker is quite a cheap piece of kit, but it can be quite powerful, not just in creating positive sentiment, but also in peer-to-peer signaling, showing I've had my vaccine, have you? Exhibit A, figure 1. I love to use a prop. And here's some of the vaccine stickers. You're welcome to have one, particularly if you've had your vaccines. And if there's anybody sitting here that's not up to date, please do get up to date. And then you can have a sticker. So it's really important to get behind this campaign and to have a record card and a series of resources that depict not just the ethnicities and the diversity of the populations, but also the lifestyles. Not everybody is rich and has an iPad and a Tesla. You know, you've really got to convey within your leaflets that you're conveying where people are in their lives, both fiscally, financially, from gender, through for sex and gender, and also through ethnicity and cultural diversity and sensitivities. One of the key strengths about this campaign that I wanted to mention, it doesn't really fit here, but I just don't care, is how critical it was to share. And we shared our information, we shared our PPE videos, our resources, we shared all of that information. I had requests from all over the world. Can we use your video? And the answer is always yes, because that's what public health practitioners do very well. They share. You know, if it works here, I don't mind if you borrow it or steal it. Just take it and use it, because there's no reason to reinvent the wheel and use precious resources, often in territories with limited resources and money. Just use what we've got. So we make the design files free so that they can be adapted and changed, and you can use the spirit of it or the center of it. You can take whatever parts of it you want to. But throughout this time, we were monitoring the concerns. We were looking at what people were saying on social media, but more properly, we're also still using our pre-existing networks, still getting signals through the NIN network, and there's a little badge there, because what we wanted to do was create cohesiveness in the network so that people could identify each other and share information with each other, even if they weren't sharing it with us. If you're good, you can have one of those too. So where we were debunking information, we were iterating the actual materials. So we have up to 18 or 19 versions of each of these, and they are going in parallel with 18 or 19 versions, well, actually 27 of the Green Book. That meant that at any given time, what the public should have received is a leaflet that was the clinically best, most correct, most accurate, and often with some difficult information. We had serious safety signals with AstraZeneca, We had myocarditis, pericarditis, we had tits, fits, we had various different signals within there. And we had to be very careful to give accurate information. So we gave them the information journey before they had the vaccine, when they were invited. Then they get their record card and their sticker at the appointment, together with a what to expect afterwards. So that if you did get any symptoms, you would then direct yourself to a health professional, to an accident emergency unit. And where that worked really well, those people recovered very well with simple treatments. Where it didn't work well and they weren't given a leaflet, the coroner mentioned that had they been given a leaflet, they might have still been here today. These resources aren't nice to have. One of my key aims in life is to get some sort of paper on, if you spend £1 or $1 on a vaccine, I want you to spend at least 10 cents or 10 pence on communicating. Because otherwise, vaccines arrive in countries and governments expect them to magically get into arms. We know, you know, and I know that there needs to be a program of publications, a buy-in from health professionals, capacity building and resource to make sure that the vaccine gets there and that there are pathways to the public health locations for all of the people that are eligible. The two things have got to meet. To make sure that we actually addressed accessibility throughout these iterations, we also provided formats in audio, British Sign Language, Braille, large print, 32 languages and 4 accessible. And we also worked with a multiplicity of different groups to tailor resources. So people with severe mental illness, those who are homeless, travelers, people with drug and alcohol problems, children, young adults, older adults, teenagers. We worked with literally 150 different groups. We never said no to them because they'd clearly identified a need. And if we don't listen and we don't act, we miss an opportunity. Multi-channel messaging is fundamentally critical. At any given time, I've got my left foot in the analog world and my right foot in the digital world, and I love both just the same. It's really important to recognize that as well as we did, there were lots of things we got wrong as well. So this is where we are right now. This is how many vaccines have been given, and this is where we are in the world. But we're now seeing people getting a little bit of vaccine fatigue. We're definitely seeing a drop-off as we increase the doses. And at the heart of that is a real literacy problem, a health literacy problem. They understand why we're boosting. They think, well, you're giving me this because the last one didn't work. You know, they don't understand about waning immunogenicity. So there's more work to be done. I was going to show you this slide, but we've talked about that enough. Boosters in spring and autumn is where we're heading. And again, we've got a new sticker there. Sadly, I didn't bring one of those. So you're going to have to come to the UK if you want one, but my door is already open. But I just want to go back because when we went in December to deliver that first vaccine to that lovely lady, we had a lot of immediate signals. Historically, when we produce video, we'd spend months planning, we'd get it signed off, we'd film it deliciously, we'd think about, epic directors and filters and just make it gorgeous. But the pandemic revealed to us that there was a sweet spot for interventions in terms of signals. And if you spend too long faffing about, you miss it completely. So we decided to make quick MIDI videos, and we still do this today. Just a few seconds, 37 seconds. Can they affect my fertility? Really important to not waste time on overproducing, getting everybody and their dog to sign it off, sending it to 101 ministries. Literally film it, do it over Zoom, who cares? It's the content that's critical. And use trusted voices. Gayatri Lintham was deliberately chosen because she's an expert on maternal vaccination, and she's also a woman that's of South Asian heritage. She was in a very good position to talk to that community and build confidence in the vaccines. So short form video, getting on with it and using good design. So this is where we are now. A quarter in the UK believe COVID was a hoax. So if we look at that little Policy Institute survey, we can see that 9% of people think it's definitely true that the pandemic was a hoax. I mean, really, that is the state of the nation. And that 14 people think it's probably true, which shows you just how much effort they think we're going to put into something like that, because that's a really energetic hoax. But luckily, we have our attitudinal tracking survey, which we do every year. And we can see here that the NHS And health professionals are the most trusted people in the UK. How are the government doing? Not so well. And social media, am I getting my health information from social media? I don't think so. But there is evidence that that is changing. I've had feedback from young people who are on TikTok and were very distraught to learn that what they'd seen wasn't safe. And I used to do this vaccine literacy thing, health literacy thing with my students back when I was a teacher. And I used to take them to the supermarket. We'd do a little walk round. And we go to that aisle, you know, that lovely aisle full of sweets and pop and lovely crisps and snacks and all sorts of things. And I'd say, you know, these are all the manufacturers, these are all the providers, these are the cereal manufacturers. What's the nutritional content? Is this good for you or not good for you? And time again, the students would be stunned. They're like, they can't sell anything in a supermarket that's not good for you. That should be illegal. They didn't understand the world of commerce. The fact that those products are all in there to make a profit. So who's online and who's left behind? This is one of my complete hobby horses, because in the UK, we've got over 11 million people that are digitally disenfranchised. They might be in digital poverty. They might have digital illiteracy. They might have a lack of reading literacy. They might have a lack of money and being able to get onto the internet. They could be in remote locations. Yes, we do have them. Not everybody has 4G. Believe me, there are people still on dial-up in the UK. So there are 4,800,000 people who will never go online at all. And that can be because they can't, but that can also be they don't want to and they don't feel the need to. So I've got to make sure that what we're doing in terms of social listening factors in that not all social listening is online. That's got to be mission critical. We've got to recognize that those that are likely to be digitally excluded are these people. They are older people, people in lower income jobs, without a job, in social housing, with disabilities, living in rural area, homeless people whose first language is not English, people who with fewer educational qualifications. I mean, literally 40% of children leave school not being able to read after 11 years. You know, that's a really important fact to recognize, and that's in the UK. We know that infodemics and misinformation cause real world harm. The Great Texas COVID tragedy is one of the most striking, obvious examples of how a powerful anti-vax movement can actually get in between people and form a real solid barrier to a take-up of a readily. These people died when they could have had a vaccine. And that's a stark realization that we've got to balance our desire to create this social listening and ethical framework, but recognize that we are balancing the risk in terms of understanding people's right to the freedom of expression and to believe what they want, but also to help them understand that in not taking certain public health interventions, that the likely result is the loss of life. So again, having a look at here, age standardized mortality for deaths involving COVID by vaccination status. This was quite a good one to use in debunking, you know, in terms of the unvaccinated and then those who received a second dose. You know, it's really important to cling to the facts, because as good as everything was, we still have examples that break your heart every day. We have all the lists, and it's beyond frustrating when you have healthy people who feel impervious and they don't take it up. And that became stark last year. So as much as I want to concentrate on infodemic management, I also want to concentrate on social listening as a default process alongside disease and infectious disease surveillance. It should be a business as usual activity. Just like the weatherman, we need to know what the weather's coming, and that way we can be prepared and we can batten down the hatches if there's a storm, and we can fire up the vaccine engine, or, you know, other health problems are available, quite frankly. It's not all about vaccines. Last year, we recognized that we were in a real period of immunity debt, and that we now have new outbreaks, and we had an Mpox situation. So we used a smallpox vaccination, and we were doing social listening throughout this. There was an awful lot of stigma-related signalling in the UK. a lot of accusations. It took us back psychologically to the early days of the HIV epidemic. There were some very similar feelings amongst the community, amongst the charities and stakeholders, especially when we were using a vaccine for smallpox. It was not well understood by this community that a smallpox vaccine would be an appropriate choice. So we had to do a number of pieces of work with the charities and with the groups to help them understand why the smallpox vaccine was the one that we could use. It was the one that we had available in storage, ready to be used. And we produced this first iteration of the vaccine information. Again, it's very important to show very positive imagery to help frame this, not just the community that was at risk of the burden of disease, but also families and relatives and friends and neighbours and parts of the community that could be affected by the disease, and also those commenting and looking at those communities that had the burden of disease. Then we did it so well that we created too much demand. And they were screaming, so you can do the job too well. So we had to then produce a leaflet, why do I have to wait for my monkeypox vaccine? Then we thought about, okay, how can we get this vaccine to spread a little bit further? So rather than doing it subcutaneously in the upper arm, it was then got permission from the manufacturers that we could actually try to do it intradermally. So we tried to do it in the lower arm. Not a good idea. Because of the tattoos, because of the lifestyle, for all sorts of reasons, very good reasons, the community said to us, no. I want it up here, under my arm, because then I can pull down my sleeve. Yeah. The other thing they told us was that we found that predominantly the people going and getting the vaccine, just like they always are, were the well-resourced, the well-engaged, the white, the young, the digitally literate. These are the people that are always going to get and gallop in the front door first. But what we found that were other ethnicities and other parts of the community literally didn't even know about monkeypox. And there's still a naive population of young men coming forward that are still oblivious. There's work to be done. So there you can see we just slightly changed the ethnicity and the framing of the information. And then we started to move through into the intradermal vaccination. And once we'd helped them to realize that this smaller dose, when given intradermally, was appropriate, we then got good take-up. So the impact of the infodemic as well, I think we've covered that already, haven't we? Let's talk about polio. I never thought in my life that we'd be dealing with a polio epidemic, a polio outbreak in the UK, but we had to deal with the polio. This was predominantly affecting the traveller and Jewish community. So we worked very well with those groups to make sure that we provided materials that were acceptable and encouraged polio uptake. Because as one Jewish elder said to me, why is it important? Why now? And you think, well, okay, let's just talk about polio, because he clearly didn't understand the imperative. He hadn't seen those images of the breathing machines, and it was important for him to understand why it was important for him to talk to his community. Same for diphtheria in the refugee population. Again, my big take-home message is that we need to adapt our channels and content. We need to accept the individual reality of personalized information. We need to recognize that most parents and most people think vaccines are safe and trust them, but work on those that don't and make our resources accessible, encourage the use of trusted sources, and segment your audience and segment your work so that you really are tailoring your information in response to social listening to address people's needs where they are in the languages and contexts that they find themselves. Thank you.
So that said, thank you so much for everyone. It's been a long day. You have been a wonderful audience, having stayed through, and for the fantastic participation. So please do join me again in thanking our wonderful panel. So that said, I also thank all our participants joining us via Zoom. We're grateful for your attention. All these presentations will be available as recordings unless consent has been withheld. So in which case we will try to provide a summary that might be useful to our audience. So that said, thank you again. Have a lovely night for those who are in Hong Kong, and a lovely day ahead elsewhere in the world. Thank you.